Right. My name is Michael Kane. I'm an assistant professor of biostatistics at Yale University. Currently, my research has mostly to do with prognostic heterogeneity, mostly in clinical trials, and then also population scale human mobility.
Thank you. Lucy, would you mind introducing yourself next?
Sure. I'm Lucy D'Agostino-McGowan. I am an assistant professor in the Mathematics and Statistics Department at Wake Forest University. And my research focuses primarily on causal inference and human data interaction and statistical communication.
Okay, thanks. Kat, would you mind going next?
Sure. So my name is Kat Hoffman. I am a research biostatistician at Weill Cornell Medicine, which is Cornell's medical school, which is in New York City. And I work with the pulmonary and critical care team, like pre-COVID and obviously since COVID hit, with pulmonologists at New York Presbyterian's Upper East Side location. And I mean, I guess we'll talk about this later, but my research has kind of changed throughout the course of the pandemic, from very much like hospital operations stuff back in during the surge of everything, to more, I guess, like inflammatory disease, like basic science stuff, as well as like outcomes of critically ill patients and, what happens when they're in the ICU and after. So, yeah.
Thanks. And last but not least, Lynsie, would you mind introducing yourself as well?
Sure. So I'm Lynsie Daley, and I work as a data analytics supervisor at Intermountain Healthcare in Salt Lake City, Utah. I lead a team of analysts who cover different clinical service domains such as laboratory, clinical engineering, imaging, and pain. And we do a lot with operational type of data versus the research side. Yeah, that's me.
Thanks. So thank you all for introducing yourselves and of course for being here. So would you mind all speaking to the kinds of data that you've been working with in relation to COVID?
Yeah, mine's pretty straightforward. It's been all like electronic health record data, mostly programmatically extracted, and then some where the doctors go in and like abstract the data themselves from the charts, but it's been all patient chart data for the most part.
For me, at the beginning of the pandemic, we really focused on also EMR data, but a lot about what was going on within our state and in the different health districts in our state. So looking at growth rates, calculating growth rates by health district. A lot of it too, in the initial reopening of the country, we were paying a lot of attention to what was going on in other states in the country as they reopened and whether the cases were surging after that point, kind of to prepare ourselves in Utah for what could happen when we did the same. And then lastly, another area to highlight, a lot of data around medical devices and locations. It's recently become really important to track the location of ventilators and how they're moving across our hospital system and where they all are. So those are kind of three of the biggest data types I've worked with.
I've had a couple of different types as well. So some of my work has been looking at quarantine durations and testing strategies. And so for that, we looked at data on kind of when people tested positive based on indexing off of when they acquired symptoms and also indexing on when they were exposed. And so that included kind of just line data on different individuals from different populations and their symptom onset date, exposure date, and their and whether or not they tested positive. And often this was serial testing, so we could see kind of over time. I've also worked with a group at Hopkins to try to come up with a way to evaluate contact tracing programs. And so for this, we came up with more of a theoretical model that incorporates like distributions of infectiousness or distributions of like incubation periods and things like that to try to look at if we can effectively get people into quarantine or isolation in a certain time and get a certain percent of them quarantined, how that kind of will impact the downstream transmissions. And so that used mostly data that was collected by other people and sort of fit to these different distributions. And then we incorporated those in a mathematical model. And then I work, I think probably a lot of people that are involved with universities and do some statistics end up on these committees, but I work with, at Wake Forest on the COVID committee to try to help inform the policies that we have for our students and faculty and staff. And so for that, my role is typically to monitor current rates on campus and sort of see if we need to be targeting testing or thinking about changing strategies and things like that. And then finally, I've been trying to help just distill publicly available data. And so essentially taking like what's available on the CDC's website or elsewhere and kind of putting it into a little bit easier to understand language to communicate to journalists and other people to try to get out into the general public.
And then, so early on, I was working on some clinical trial design. So early on in the pandemic, there were a lot of people running clinical trials, not kind of like the large scale clinical trials, but kind of more community level or university level. So a lot of what we were doing early on was thinking about what are the data that we can be collecting that's going to be useful across trials, because a lot of what we were thinking about is how do we pool data, and then how do we take into account that for a lot of these trials we're targeting different populations. So I worked on kind of the design for collecting those data and describing the data that were needed for clinical trials. For human mobility, I tend to work with cell tower data. So right now, all of our cell phones are connected to a tower. As we move further and further away from that tower and closer to another tower, we eventually get handed off. And so a lot of the data a lot of the mobility data I look at is kind of the aggregate, where groups of people moving in aggregate. So this would be kind of at a larger scale than something like contact tracing. And then I've been spending a lot of time then thinking about how do we think about integrating outbreak data or other COVID data into that mobility data. And then finally, I'm a member of the COVID-19 Data Forum, which is a collaboration mostly between Stanford and the R Foundation. And a lot of that was us helping promote other people with data sources. So that was like the Odyssey group, which is in the UK. They have a lot of real world clinical data that you can that you can get access to. So we were encouraging them to talk about the data sources that they had, talk about how do you actually access it, and then also and it was the same for other groups. There was one at Carnegie Mellon that does a lot of that was doing a lot of outbreak forecasting. So so I was kind of into like the design for the data that we wanted, then analysis for some of these larger data sets, and then also the promotion of other groups that were that had data that were willing to share it.
That's always interesting to me to hear just how many different angles there are to come at and how many different data sources for this one topic. But kind of as a follow-up to that, what sort of challenges in terms of data quality or lack of measurement and lack of data have you encountered while working with COVID data, and how have you responded to these challenges?
I think a main one for some of the work, especially for the work that I've done that's sort of more of these kind of theoretical mathematical models, is that the viral dynamics are sort of constantly changing. And so typically in like a statistics study, or at least the ones that I had done previously, you kind of get a cohort and you can like fit a model to that cohort. And so the fact that things are changing over time doesn't necessarily impact that cohort unless you are following people over time, in which case you can just include time as a variable. But when we're trying to kind of come up with these theoretical models that like will help figure out, viral dynamics and things like that, if the virus changes, then you have to go in and update all of those underlying assumptions and distributions. And so, for example, recently, we have this new Delta variant that has been introduced that has a much shorter incubation period as compared to the wild type or original COVID virus. And so that, changes the dynamics of contact tracing and things like that, because it changes how quickly it could potentially pass on to somebody else. And so this type of thing has been really challenging, trying to sort of keep up with that. as things progress, because it sort of feels like once we get everything in line with whatever's happening currently, it all of a sudden feels outdated because something new ends up coming about. So that's been one big piece. And then of course, the other one is just the imperfect data. We have huge missing data problems. There's imperfect testing and things like that. And so imperfect recollection of the ordering of symptoms. So for example, when we're trying to do contact tracing and we think that person A infected person B, it's possible that the reverse is true. And so it becomes really challenging to try to draw these connections and be able to draw inference on kind of things like how this virus is transmitting, and even to be able to answer really simple questions ends up becoming really complicated.
So one of the big challenges in clinical trials, and again, this is mostly early on, is that, like I said, a lot of people had different trials, and a lot of people are testing very different things. So when you're doing a clinical trial, you usually decide on what are your endpoints, and you usually evaluate the hypothesis based on the primary endpoints. One of the big challenges that we had was that people were looking at these, they were targeting very different populations, and they were thinking about very different endpoints. And I think one of the things that we push very hard is that there's also this notion of a secondary endpoint. So it's not what you're going to evaluate the trial based on, but these are other things that you think are going to be that are going to be useful. So a lot of when we were working on the design for trials was to realize that whoever's running the trial they have their own set of primary endpoints. We're probably not going to be able to change that very much. But we really wanted to get them to have a more uniform set of secondary endpoints, and then also have more uniform set of baseline characteristics. And the reason that we wanted to do this is with varying success, is that we really want to be able to pool the data in the end, right? Because you have a lot of people having the disease, a lot of people with various severity. The problem is if the trials are designed poorly, or if they're not designed in a way that's compatible, then those data are not, you can't leverage, or you can't pool them. Basically, it doesn't make sense to pool them. So that was, that was one of our big challenges early on, was getting the trialists to agree on a set of secondary endpoints. For the human mobility data, that's also been tricky, and probably in a way that's related, but not the same as contact tracing, because human mobility is kind of, we're a little less interested, or we don't have data at a resolution to say whether or not two people have come into contact with each other, but we can say that they're within a given area. So a cell phone area, a lot of times is order tens of meters to a place that's really densely populated, to kilometers, to places that are pretty sparsely populated. So then one of the issue there is, then what is the right model for thinking about how people are going to transmit both within a tower coverage region, and then how does that translate to transmission across tower regions? And that's something we're still working on.
I think for us, one of the biggest issues that I've observed is, and I think this has been alluded to, is just the quickly changing target of what we need to be looking at and how that's changed over time. And so we may have data for something and be set to go, and then we get a curveball thrown at us and quickly have to identify ways to secure other data sources. Some examples that I've observed at Intermountain of that is, when we, at the beginning of the pandemic, identifying a COVID positive patient was very straightforward. But then once the pandemic has gone on, you have patients coming back as inpatients for other conditions. And because they were COVID positive, that was alerting in our bed occupancy dashboard. And they weren't really there for a COVID positive case. They were there for something else. So then we had to kind of go back and put in different restraints and things to kick out those who were not active COVID positive patients. And then also in the beginning, age wasn't really something we were looking at. And now with the Delta variant and so much interest being placed in kids and transmission, age has become important. And we had to quickly kind of update everything to have a way to look into, drill down into different age categories. And then I think just another thing that was difficult for us is that we have a large analyst organization at Intermountain Healthcare, and naturally at the beginning of the pandemic, everybody was kind of looking at everything, and there were pockets of information everywhere. And so trying to rein that back and get to one source of truth for the organization and for senior and upper leadership, trying to create standards for measurements, and ultimately it was settled on to have one kind of COVID-19 operations dashboard that's the gold standard for Intermountain, and that's kind of how we overcame those things. But yeah, lots of messy data quality issues going on during the pandemic.
Lynsie, have there been any like when you are looking at some of those patterns attributable to different strains of the virus, like what % are being noted as the Delta variant or other variants? I guess what % of those do you have tagged with which it may be?
So we're not actually tagging at the hospital level what kind of strain of the virus they have. I can tell you that in Utah right now, it is the overwhelming majority of cases, plus 90%, I think. But what we were struggling with was just trying to identify, is this COVID positive patient here for COVID, or was this a past case that has been resolved and now they're here inpatient for some other reason?
Has it gotten difficult because the standard of care has changed a lot, right? We now know a lot more about what should happen to somebody who's showing severe symptoms. So that becomes a moving target also, right?
Yeah, I would think so, definitely.
That's all really interesting. I know that some of you had indicated that you had some slides or visualizations to share to kind of demonstrate some of your work. So maybe this is a good time to do that. Kat, do you want to maybe go first with yours?
Yeah, sure. So actually, I was just going to share a blog post that I did last year on some of my favorite functions that maybe since this is an ARC, our audience might like to look at, but I'll just share one of them from it, because it's, obviously kind of hard to share like all the work that we've done so far. But yeah, this was just a top 5 coding tricks that I learned. If you guys want to check it out later, I can put the link in the chat. This was a tweet from my grandma, or a text from my grandma. My grandma would always like ask about like different studies. It's like she just thought I could do whatever study that I wanted. And so like all of April last 2020, she wanted to know like these random questions that she would see on the news, which was cute. But that's just an aside. So the function that I wanted to share, in case you guys didn't know about it yet, is, well, it's a package. It's called TidyLog, and if you load it after tidyverse, it will sort of spit back messages whenever you like mutate or select or do different joins. And I found that super, super helpful when I was constantly trying to join data sets during the like really fast pace during the surge and everything. Because if you're trying to merge 2 data sets, and like we said, there's lots of missing data, lots of like different patients that can be in different places, it will tell you like how many rows match from one data set to the next, and alerted me to honestly so many problems when I was joining data sets. So yeah, I can put the link to this blog post in the chat, but TidyLog was my favorite one of these. There are some other ones like GT Summary is an amazing package for tables and all sorts of stuff. But yeah, check out TidyLog if you haven't already, because it saved me a lot of headaches.
That's really useful. Mike, do you want to go next with your slides?
Sure. So I'm going to show some of the mobility work that we've been doing lately. So this is so these are the these are the mobility groups for the state of Connecticut. some of the colors aren't that well distinguished, but the idea is that basically you have cell towers, people are moving between those tower regions. If you have more people moving between those regions, you can think of those as somehow being more connected than others. So you can think of this as a graphical model, which we can then do clustering on. So one of the things that we wanted to see early on is, given that we have this mobility data, do we have kind of coherent spatial clusters? And these are the spatial clusters for the state of Connecticut. What was originally surprising to us, like I said, we had no idea what these are going to look like, or if we were going to get any kind of coherence. When it comes to the spatial clusters, they do correspond to kind of not quite counties, but kind of regions that we're familiar with. And I guess as we're thinking about for COVID-19, one of the things that we had proposed is that we wanted to, since these areas are pretty coherent, you do get a lot of communication or just movement of individuals in these regions. So, as you think about how this relates to an outbreak or a more localized outbreak, basically what happens is the concentration of cases in a given region will begin to increase. So if that's the case, then we usually want to say, then what are the regions that are close? Do you get a lot of communication of individuals to those regions? In which case, those would be the places that you'd look to see an outbreak afterwards. So the idea so what we're pursuing now is, given that we have those things, can we then turn around and deliver those to individuals? Maybe for someplace like New Haven, for me, maybe I don't have to go into work every day, and I can always teach from where I am, which is a little bit further east. So if it were the case that I were to see that there's a larger outbreak in New Haven, I would have the option then of not going in, just because I can work from home, and that would be kind of to help at least stymie the outbreak to the adjacent regions. The other thing we did with this is that you can then think about, let's assume that we do have an outbreak that's occurring, and let's say that we have kind of varying degrees of mobility between either regions or even at the tower level. And so one of the things that we did find is that if you do have a lot of restriction for movement, so basically you make it so that it's difficult for one region to spread disease to another area, what can happen sometimes is it can look like you have a secondary outbreak. And the reason for that is basically that you have, it can look like you have a secondary outbreak for the larger region. The reason is that you have a region where you have an outbreak. You have pretty good control over who's moving to the adjacent regions. Basically, how well is it going to spread? But when you restrict movement, what will happen then is it takes a lot longer for people that are sick in one of the regions to get to the other one. And then usually within the region, you have better communication. So what happens is, here you have essentially an outbreak in one region. It takes a long time for it to get to one of the other regions. So it looks like you have a global secondary outbreak, when really all that's happened is you restrict movement, and it's taken longer for the disease to get to another place. So this is something that this is related to something that we see kind of in the news a lot, where you see outbreaks in different areas. It's attributable to, it's usually attributed to a lot of different things, like a lot of times policy. One of the takeaways from this, though, is we don't actually know if that's the case, and we don't always have great ways to be able to test whether or not that's true. So that was, those were the slides.
Mike, we have a question that came in from Wheela in chat, and she asks, what do the different, I lost it. What do the different colored dots represent on the previous slide? And then relatedly, I was also wondering if you can talk about what features went into the clustering.
Yeah, so the dots are a subset and noisy version of locations for cell regions. So we don't show exactly where they are, but then, so each one of those dots is a proxy for a cell tower or set of cell towers. The colors represent the spatial region in which you have basically more people are moving between these pink points than they are moving to any of the other places. So you have people people in here tend to stay in here and move around in here, but then they will move to adjacent regions, right? They can't really hop because there's not, because in general people are moving, either bikes, walking, or cars. They tend not to fly within Connecticut all that much. So that's what these points represent. Basically these spatial communities or these spatial clusters. And that was the basis for then looking at, if we think then about what happens during these different scenarios where we're restricting mobility to different degrees, how does that affect the spread of the disease for, in this case, it was for the region as a whole, in this case, Connecticut. Yeah, let me check the chat. We'll see if I answered that question or no.
I think
Okay.
so. She says, thank you for the explanation.
All right.
Thanks, Mike.
Yep.
All right, thanks so much, Mike. Okay, Lynsie, do you want to do something you want to share as well?
Yeah, so let me share my screen here. So this is something that we worked on at the beginning again, and it's more cool than, I mean, it did inform some things, but it was just a really cool concept. So what we did is so in R, we calculated the daily case growth rate in each county in the US. And then I moved this data over to Tableau. And what we did was created a time-lapse map of the growth throughout time at the beginning of the pandemic. So if I push play, we like to call this a fire map because it kind of shows how COVID is burning throughout the country at the beginning. So here we start, at the end of February, and then the hotter the color, the bigger the case growth rate is. You can kind of see how it spreads throughout the country at the beginning and where it's kind of waxing and waning. And this is really quickly lapsing through right now, but if you did it slower, you could kind of study where things are going and how it's spreading. And it was a really cool concept to us to be able to kind of visually represent this. And so now we're like into July of 2020, and you can see it's through the whole country. You can kind of see where it's burning hotter in some places than others. And then I've got it stopping here at the end of July, but something really cool that was fun to visualize.
Lynsie, that's awesome. Did you have any issues with certain areas reporting, like not at consistent periods or at places just not reporting?
Yeah, so these white areas are all of the areas where we didn't see any data coming in. And then it was always a concern. There were some of the smaller areas where we weren't getting daily data. So that kind of skewed things, or it was fun to play around with the coloring and where, like, sort of what we would define as like going from the transition to yellow to orange to red, because naturally if you have a small county with a small number of cases, you're going to see case growth rates that jump really high and then go back to zero really quickly. And so kind of messing with how we're actually visualizing the heat was interesting too, to try to get rid of that artifact as well.
Thank you.
Sure.
Okay, so for all of you, have there been things that you found throughout your work with COVID data that have taken you by surprise, or that really were some findings that wouldn't have been obvious going into it? And kind of as a related question, how has that, or just your work with COVID more generally, changed throughout the pandemic?
One thing, and this also sort of ties in, I saw in the chat someone had asked about pregnant or pediatric patients. And I think maybe Rachel had asked that question. And I don't personally work with either of those data sets, but I'm like personally, I was pregnant during part of the pandemic, and I have two little ones. And so it's like something that I've looked into just personally. And the data is really challenging. Obviously, it's I think others here, probably Lynsie can speak to it because I know it sounds like she's been working with some hospital data too, but for just some things that I've been thinking about when I'm trying to assess the data personally that makes it more challenging, like for pediatric patients, for example, when you think about like definitions for hospitalization, for very, very young patients, like patients like my daughter who are less than 1, the threshold for hospitalization is sometimes lower because they want to make sure that everything's okay in a very young baby. And so when you're trying to look at rates, it can be hard to assess like what the difference between kind of rates of hospitalization because it was like absolutely necessary to be hospitalized and rates of hospitalization because there was like precautions being taken. It's hard. It makes it hard to make comparisons in that group to older groups. And similarly for thinking about transmission in children, the question that I had mentioned earlier about kind of transmission between A to B or B to A is it's hard to parse out, especially when there's variation in types of symptoms. And so we know that children, at least historically, tend to have fewer symptoms than adults. And so even, so if they potentially are the index case or the primary case, it's possible to not necessarily know that because they might not have had symptoms and passed on to a parent. So sometimes those kinds of like quantifying transmission can be really challenging. So anyways, these are challenges that I face just trying to get these questions answered for myself, but not ones that I've actually have good answers to, but just when kind of thinking from a causal perspective at how all this, the dynamics of this, there are a lot of things that make it really challenging to assess the types of answers. So there might be other panelists that have actual answers to these questions, but I can pose the questions.
Thanks, Lucy. Yeah, let me read that out loud just so it's on the record. And if any panelists have further thoughts or comments, no, that's totally fine. So Rachel says, my name is Rachel and I'm a recent MPH grad from Columbia. I'm wondering if any of you have had experience working with data from pregnant or, as Lynsie mentioned, pediatric populations. I used to work in pediatrics, so I'm curious about any issues with data availability for vulnerable populations. And so Lucy, that was a great some great points you made to that topic. Lynsie, did you have anything you wanted to add? Because I know that you had mentioned pediatrics in your.
Yeah, I'm not sure of the kind of where the data quality issues would be with pediatrics. Just know that pediatrics and elderly populations, pregnant populations have become more important as the pandemic has gone on.
And Joyce, this is a great question that came up in chat, which I think we're going to hit on in a little bit in some of our future questions, but I'll put it out there and maybe we can start talking about it now. For any and all speakers, based on your work, what do you think the media is really getting wrong about COVID? And I think actually this fits pretty nicely in with one of the next questions we were thinking about, which are key learnings and strategies for communicating data findings to your audience. So I know, Lucy, you have some thoughts on that, so maybe I'll kick it over to you.
Yeah, the big one that I see kind of consistently, and this is kind of across statistics, is just getting the denominators wrong. So I think this is the question of sort of what the denominator is that that the journalist or the kind of just general public is interested in, and whether or not that's the denominator that's actually being used. So like a classic example is when we first were starting to hear a lot about breakthrough cases. And even still, a lot of times the statistics that we see are like the percent of cases that are vaccinated or the percent of hospitalized people who are vaccinated, as opposed to the percent of vaccinated that are hospitalized or the percent of vaccinated that are turning up as cases. And I think this causes a lot of confusion. Part of that is a data availability question. So for a hospital knows their census. They know how many people are in their hospital. And now, because a lot of hospitals are tracking it, they often know the vaccination status of their patients. So the number that is easier for them to be able to produce is going to be the percent of, among all those hospitalized, how many were vaccinated, how many were unvaccinated, or what percent of each of those are. So it makes sense that ends up being kind of what's reported out. But unfortunately, that can sort of muddy the water, because as more and more people are vaccinated, we expect those percentages to increase, even if the actual frequency doesn't change or decreases. And so that's been a real struggle that I have had, trying to sort of make sure that when folks are reporting these things, that they're kind of being very cautious about what denominator they're using, sort of among what population are they speaking. And I myself, I've been trying, this is a goal of mine, is to be able to communicate this clearly to journalists and general public and everything. And I have been misquoted on this even in headlines. I had a local newspaper interview me, and they made the headline something like, Wake Forest researcher says that breakthrough cases are very rare. And like, that was not what I said at all. I didn't say anything about the frequency of these cases. In fact, I think that they're common. I was just trying to state that, you know, when you're thinking about like not necessarily thinking about if they're rare or not rare, but thinking about kind of the percent that are among kind of, we want to think about them among vaccinated people or unvaccinated people, as opposed to like among all cases, what percent were vaccinated, because as more people get vaccinated, that percent is going to increase. So anyways, I think this is a really hard question. To me, that's been the big thing, that people sort of focusing on the wrong parts of the numbers. Maybe even just the fact that that percentages are being used instead of actual frequencies, I think sometimes also can contribute to this confusion. But I don't have a great solution to that either, other than when I try now to repeat myself many times when I'm explaining this to journalists. And if they're willing, I ask them to send me the headlines. Often they don't, but I ask if they can send me a headline to check beforehand to make sure that it actually represents what I've been saying, and things like that.
So this is kind of related to that as well, but since the beginning of the pandemic, what failures, either in reporting or research or in any other category, have you observed, and what can be learned from them moving forward?
So one thing that I've seen is, I think there's been kind of an impedance mismatch between the results that have been put out by public health and by what's been actionable. So one of the really interesting things that we found out is, this was through the COVID-19 data forum, and this was from the Delphi group. So this is a group at CMU that does forecasting for COVID-19. One of the things that they figured out is, so they were forecasting outbreaks for given regions. One of the really interesting observations they had was that doing, basically curve fitting, they said, or they believe they had pretty accurate estimates for up to, they were saying, between 4 and 6 weeks. And the reason that they were doing this curve fitting, which is kind of basic, it doesn't require a lot of domain knowledge like a lot of the epidemiologists have. But at the same time, that was kind of within, basically, when they were talking to decision makers, the decision makers needed at least 3 to 4 weeks. So this is one of these cases where, they were able to come out with estimates, and it's barely enough time for people that are making decisions to actually make decisions and have them be meaningful. It seems like there's been a lot of cases where there are a lot of things we know, but as it hasn't scaled very well to the pandemic, or it hasn't, or it's been difficult to actually make it, to actually put it into practice by decision makers. So I don't have a lot of other examples, but I think that the Delphi group, that observation for, this is what we can estimate, this is how long decision makers need, is a good example where, where they were able to match the impedance there. But I think there have been a lot of cases where it's been difficult.
Mike, have there been strategies to make that process easier, like to speed up the time between, or anything like that? Has that been something that's been learned or figured out?
It's a good question. I don't know. And I think part of the issue is that I think before the pandemic, there were a lot of people were oriented towards, the analyses that they were doing, that they're able to publish on and be able to say things that are of value. There's still, we know these things, a lot of them probably could be put better into practice, but there is still this this mismatch or this difficulty with actually getting to decision makers. Like if you think about like for the COVID-19 data forum, these are, it's a couple, we had a couple of big groups that were able to speak about the things that they were doing, but we were not able to get decision makers because we wanted to find out how do they incorporate data. And then when we were asking people that are providing the data, like Odyssey or Delphi, they have like one or two kind of successes where they're able to get to somebody and say, hey, we can start providing this data. But the problem is the decision makers don't always know how to integrate that information. And that's probably kind of a similar problem that, most people have with integrating with integrating and contextualizing what we get in the media. So I think there's still a big mismatch there. I think there's a lot of opportunity to be able to handle that better. And I think it kind of comes as a combination of, for people in public health thinking about how can what they're doing be put into practice, and then also think about what are the bridges that need to be built such that when that knowledge or information is being created, that it can actually be used to make better decisions.
Thank you.
Thank you.
Wheela also says in chat, for me personally, more in the beginning, I've seen just raw data being used to justify or refute policies, which seemed very misleading for me. And we also have a question that came in from Noelle. She says, I'm familiar with the NIH's N3C aggregated data repository. What are some other accessible data sources that pool across states and care systems?
So one of the big ones that we were using in the beginning was the Johns Hopkins data source by county. And our data architects actually went and scraped that and loaded that into our EDW. And that's how we were coming up with those maps and things.
Yeah, the New York Times also has some data, so that they have data that kind of pretty closely matches the Hopkins data in terms of cases. And then they also have collected some data on like college campus numbers, and I believe they have a couple other data sets as well that you can get from their GitHub page.
So we as our ladies have one last question for our panelists. I think we'll have a few minutes after for any further audience questions. So just before I ask this, if anyone has anything else that you're hoping to hear answered by our panelists, please feel free to throw that in the chat over the next couple of minutes. But our last question for you all is just, what messages would you want to get across, or do you feel that it's most important for the public to know?
Yeah, so I guess for me, one, I guess I didn't speak too much on failures. I think, you guys covered them pretty well, but there were a lot of things that went wrong with COVID research and just policy making and everything. But I do think in the end, like, people were all trying their best, and it is a very unprecedented event to have to work on and research in real time something that's like actively affecting everyone's lives so deeply. And I mean, as many failures as I saw with science, in some ways failures, I also think it's just really important that we remember how many things we have accomplished with science during this pandemic. Like, I mean, we've figured out a decent number of treatments for COVID in, less than a year time for a new disease. And, we have multiple vaccines, safe and effective vaccines going. And there's pros and cons of like all research flipping to COVID pretty much. But I do think it's a testament to science that there has been this accumulation of research that says, in more or less, it says the same things. That's the whole point of science. The whole point of research is to try and have multiple people working on the same things to get to sort of a consensus on what we should do next. And yes, it could be faster. It could be just done more methodically. But I do have sort of, in some ways, hope from the pandemic, from seeing the way that science was able to work.
Yeah, I definitely appreciate that infusion of optimism. And I think, I don't know, it's just kind of funny to think that when we first started talking about this panel, And I think it was like July or August, we were having a conversation of, are people even still going to be interested in COVID? It seems like it's, people are really over it and it's kind of going away. And then here we are and it's Delta and people are re-quarantining. So I think with all the pessimism, it is really important to remember how far we have come as well. So thank you for that. So yeah, I'm not seeing any more questions in the chat, but if anyone has anything else you want to hear answered, now is your time to throw that in.
I think too, building on what Kat said, like that we have a lot of tools available to us now. I think there's been some kind of, to build on the optimism, there's been some pessimism because it is frustrating to be kind of feeling like we're sliding back in, or maybe slid back into this kind of heightened number of cases and hospitalizations and everything. But one positive is that we do have a lot more tools than we did this time last year. So thinking about, for example, going into the holidays last year, many people were really having to restructure how they do holidays. And this year, I think there still needs to be thought put into it, but we have tools like, for example, vaccines and boosters now are available. So that's really positive for people who are vaccines for everyone and boosters for people who are vulnerable. And in addition, testing is becoming much more available. Obviously, we wish it was even more available, but things like rapid tests are widely available, kind of if you keep tabs on in-stock alerts and things like that. And those type of tools are things that we didn't have last year. And so being able to do something like take a rapid test before you gather with family members is something that we can do now that we couldn't do before. So I think just sort of keeping in mind that we now have tools that we didn't have previously that we can use to actually kind of keep limping forward and not feeling like we're sort of still in this rut, which I think is really positive as well.
I'll add to that point too, of things that are now more available than they were. I think just masks and type of masks, and also adherence to masks. I mean, riding the New York City subway, people I think in general have been really thoughtful and wearing them. So that's always kind of a nice thing when you have sort of community compliance for things that we know work and work well. And like N95 masks are back on shelves at places like Home Depot. And so that's for, if people need to travel for work or whatever the case may be, that's also been another interesting trend I've seen. Well, we'll keep chat open if any more questions come in. Oh, here we go. We got one from Willa. Lynsie, for the data map that you had shown, do you have any predictions for this coming up winter with respect to COVID hospitalizations?
So the map that I showed was not predictive in nature. It was kind of looking back, but based on the work that other analysts and what we're seeing with the data at Intermountain, which a lot of other data analysts are involved in, I really think it's going to be really kind of hit and miss throughout the country. I think a lot of it is going to be dependent on the rate of vaccination uptake in different areas. So I don't think it's going to look the same all over the country. And for example, Utah has just barely over half of the population fully vaccinated, and we are currently in a surge. Our hospitals have stopped elective surgeries. Our ICUs are overflowing. We're in a bad situation right now, and I could envision, that as the weather gets colder and if we don't get a significant more number of people vaccinated, that it could be kind of ugly here this winter. But in other communities, they may be better prepared than us.
I think one thing, I'll put it in the chat. There are several, I know Michael mentioned some groups that are doing kind of forecasting. There's one that I've worked with some of the folks that work on the scenario modeling hub, which is they do an ensemble model. So they have several groups that create models independently, and then they kind of ensemble them all together. And I will say that the trends that they're seeing are somewhat optimistic, which is great. They do show that we're gonna shortly across the country peak and then come down. But as Lynsie mentioned, there's variability within states, and in that link that I just posted, you can actually here, maybe I'll share my screen quickly so you can see kind of how this looks. But you can look at these different rates, you can also look at them by state. So you can look at them one state at a time, or you can look at just state deviations, which allow you to, or trend maps, which basically let you look across the whole US. So it projects kind of in different areas. Some places that are going to have, they're predicting kind of sharp declines because they've already hit a peak, in some places that maybe still have higher up to go because there hasn't been a peak yet. And so anyways, these confidence intervals obviously are very, very large, but I found this somewhat encouraging. This particular, I'll show kind of the overall, they look at a couple of different scenarios. One thing to notice, they did get some press for being optimistic, but even in kind of their most optimistic settings, we're not getting down to like July levels until like March or April. So while it's a decline, it's a slow decline. And certainly there's going to be a lot that happens in between now and then. Even if we don't see a rise in cases, there still are a large number of people that are expected to be infected and hospitalized over that time. But anyways, I found this model or this ensemble helpful for thinking through some of those questions.
No, thanks for sharing that. I didn't even know that existed. But there's another question in the chat. Can the panelists speak to the collaborations with members within and out of their own respective fields of study for the research?
Well, I'm a biostatistician by training, and I have been working with biostatisticians, but also a lot of epidemiologists and infectious disease docs. I feel like that's probably the most common. I guess I don't want to speak for everyone else, but most of the collaborations that I've seen sort of are a combination of folks that are sort of statistically minded and then have more of the content matter expertise.
So for the clinical trial stuff, I tend to work more with clinicians who tend to know enough statistics to be dangerous. And a lot of times I end up learning enough medicine to be dangerous. And then like together we try to keep each other out of danger. And then for the mobility stuff, that tends to be with people that are more computer scientists, less epidemiologists. And I've been mostly focusing on mobility because I think it's an important underlying concept that has applications not just in epidemiology but in other areas.
Okay, I'm not seeing anything else coming through in the chat, so I'll just take a moment to say thank you to all of our panelists for your time today and your prep time and all of your insights and thoughts today. This has been really fantastic. And also thank you to everyone who attended and took some time out of your lunch break and asked some really great questions for our conversation today. And also to my co-host, Emily, for all of your help as well. I don't know if you have any final thoughts, Emily, or anything else you want to throw out, but.
I don't. Just thank you so much to our panelists and for everyone as well for your engagement and really fantastic questions.